these were two very different trials, actually. And, initially I had thought that, I was going to have a hard time drawing parallels, but I think, what was really the take home for both of these studies is that, we sometimes can underestimate signals of benefit in looking at everybody together. But then if we delve into the specific patients who had benefit, we start to see patterns. So we can start with the first study, which is the MEDISARC trial. And this was a randomized phase 2 trial that has been going on for quite a while that compared frontline sarcoma patients to either doxorubicin, the standard of care, to Durvalumab and Tremelimumab, which is CTLA-4 and PD-1 blockade. So, I was really impressed because I think they were bold in the way they designed this study, bringing it frontline. There's a thought in the community that immunotherapy may work better before patients have been heavily pretreated. And certainly for the other study I just presented, those were very heavily pretreated patients. So there was a hope that bringing it in earlier would work better. And then also they looked at overall survival. So, one of the peculiar things with immunotherapy is that, the response rate might be modest or the progression-free survival, if you look at the median, might be modest, but patients can still live longer having been treated with immunotherapy, even if they don't necessarily respond. And they've seen this in numerous other cancer types. So they set out to look and see if that was true in sarcomas. And there's very little data looking at that so far in the trials that have been done. So in any case, when we looked at this trial, there was not a significant difference in the overall survival from a statistical perspective. However, there was a trend towards these survival curves starting to separate. And I think, the take home here is that if patients got through that initial period of time where there's rapid progression on both arms, really, there's some hints that the overall survival may actually improve. And, this needs to be looked at in more detail to see. So if you can if you're not an early progressor, sort of this late benefit group of patients, that immunotherapy may actually be quite helpful. There are some issues with the trial simply because the doxorubicin performed fairly poorly compared to some of the more contemporary doxorubicin containing trials. So that may impact the way that these arms were compared. But I think it really does set a benchmark, a standard that says, these are actually pretty similar. Like the immunotherapy wasn't worse than doxorubicin. And so it opens the door for future randomized studies, particularly combinations, which I'm very interested in with doxorubicin plus immunotherapy, or sequentially, like do you do immunotherapy and then doxorubicin, or doxorubicin and then immunotherapy? So it was a very important study, even if on the surface, there wasn't a significant difference. It raises some important questions for further investigation. And then the TOMAS2 study, this was a different study, but basically a phase 2 randomized study looking at a standard chemotherapy, Trabectedin, in combination or with or without Olaparib, which is a PARP inhibitor. And so the idea here is that many cancers have a defect in DNA repair as part of their genetic background, and it presents an opportunity to exploit if a tumor cell is dependent on certain pathways of DNA repair that they can then be blocked therapeutically. The tumor may now have no choice, be unable to repair its DNA damage, and then die. And so one of the most common pathways that tumors depend on is homologous repair, as well as base excision repair and nucleotide excision repair. So PARP inhibitors block the homologous recombination repair pathway. And basically, the idea was that if you instill DNA damage with Trabectedin, there's some data that patients that actually had defects in homologous repair may be sensitive to Trabectedin. And so the idea was that could you improve that even further by blocking PARP? So again, this study at first, the differences between the two arms, with or without PARP, didn't look statistically different. But then they went on and presented some early preliminary biomarker data. And what's really exciting to see is that tumors that had this underlying deficiency in homologous repair had a much better response to the combination therapy. And the toxicity was more when you had the two together. So it's nice to see a group of patients that may potentially benefit. And this effect with PARP inhibitors has actually been recently seen in other types of cancer, like endometrial cancer and some others. So again, it's just nice to see a mechanism that actually plays out in the study. So this is not going to be a treatment for everybody, but hopefully, with further biomarker work, we can identify patients who are likely to benefit.